Good morning, everyone. Hope you all are doing great. And today's lecture topic is on sex hormone and contraception. I am Dr. M.I.M. Shuja from Faculty of Medicine, Rajarata University of Sri Lanka. Yeah, sex hormone and oral contraceptive. When what are the hormones denoted as sex hormone? Mainly testosterone, estrogen, and progesterone. So before we go into uh, deep into pharmacology, we'll be going in deep because here lot of MCQ points you have to remember. Okay, just basic outline. The hormone progesterone is produced from corpus luteum. What are the function of it? What happens if the progesterone is on high level in your body? What happens if it is in lower level? So these kind of idea we have to know before going into this. Just go through this. For this a simpler version of that. The estrogen is mainly in female, stimulate female secondary sexual characteristics, prepare of the wall of uterus, and controls ovulation. If there is a problem in the estrogen secretion, if it is low, then your secondary sexual characteristics are not developed. Ovulation is not regulated like that. You have to know. So you have to remember this hypothalamic, pituitary, gonadotrophin or gonadal axis, HPG. In the male, hypothalamus secretes GnRH, it acts on anterior pituitary, that in turn secrete FSH and LHS. They are act respectively on Sertoli cell and Leydig cell, secrete testosterone and help in spermatogenesis. The ABP is androgen binding protein. In the female, hypothalamo-pituitary gonadal axis is hypothalamus secrete GnRH, act on anterior pituitary, that secrete FSH and LH, which act on ovary and secrete estrogen and progesterone that regulate activity in the uterus. Meantime, these estrogen gives most of the time they give negative feedback. So whenever you have more estrogen, your GnRH secretion is reduced, so FSH LH reduced. But near the ovulation, that feedback is positive. When ovaries secrete estrogen and progesterone, further they increase secretion of GnRH, FSH and LH. That leads to LH surge that will help in ovulation. Remember this physiology because it depends on this physiology. We will be working mainly in contraception. So if we are going to block this axis, this normal axis, we will not get pregnant. So in contraception, what we do is we are going to give drug which is going to block this normal HPG axis and block this positive feedback. Remember that. Now we'll see how the steroid hormone acts. Steroid hormones are mainly hydrophobic. That means they are afraid of water. They are lipid soluble, not water soluble. So when sorry, when the steroid hormone it comes into the blood, it binds with sex binding globulin protein. Then the free portion of the steroid, which is not bound, it diffuses through the cell. It enters the cytoplasm of the cell. In the cytoplasm, it will join with its receptor. That means it forms receptor steroid complex. These complex in turn come and bind with the DNA. Then either it activate or depress the action of DNA or particular gene. If it is activated, that gene undergo transcription, produce mRNA and produce new proteins. Then that will participate in cellular activities and give the cell response. This is a kind of slow process because it has to do changes in the DNA level. But there are steroid receptors in the cell that gives you a rapid response. That's why in allergic or anaphylactic reaction, you are giving hydrocortisone. So that immediate effect is by the hydrocortisone bind with the cell surface receptor. But in the long effect is via it's binding to the nuclear receptor. Okay, know that. These are very basic things. A bit pharmacokinetics on steroids. I have put all the things in a point format. These all are very important for your MCQ and your future practicing as a medical practitioner. Steroid sex hormones are well absorbed through the skin and gut. Most sex hormones are subject to extensive hepatic metabolic inactivation. That means extensive hepatic metabolism means bioactivity will be low or bioavailability will be low. So as the hepatic metabolism is extensive, you have to give large oral doses to meet a certain action. There is a enterohepatic circulation also. Some people say enterohepatic circulation because when you give a drug, it absorbs in the gut and goes to the liver or certain part of the body, then come back to liver, then it excreted into the gut again. Then there are some biological deformation, then again it's reabsorbed and goes to the body, come via the liver. So that is enterohepatic circulation, gut and liver circulation. So via this circulation, the efficacy is increased because again and again the drug is get used in your body. This may be interrupted by severe diarrhea. In a diarrhea, the colonic membrane or the what you have residue and cilia in your epithelium of the colon, those are affected, so you cannot reabsorb, so the efficacy is lost. That's a very famous question they will ask. Why there is a contraceptive failure in diarrhea patient who is on oral contraceptive pill? So the explanation I will tell you in the later part of the lecture, but know it. That's a very famous question, SCQ, and you should be able to give an elaborative answer for that. Some non-steroidal analogs are metabolized more slowly. There are sustained or slow release preparation also available. They carried in the blood, extensively bound to sex hormone binding globulin. Had been very small portion is freely available. So, what are the disorders can happen in the reproductive tract? Mainly we divide into three: either disruption of the hypothalamus, pituitary, gonadal axis, or inappropriate growth of hormone dependent tissue. Like, what are the hormone dependent tissues? Endometrium, uterus, ovary, and breast. A reduced sex hormone secretion. If you don't get enough estrogen and testosterone, your secondary sexual characteristics are reduced, and especially the problem comes in your libido. The desire to sex is reduced. That's a serious problem. So, disruption of the HCG axis, it can cause polycystic ovarian syndrome or prolactinoma. Then, inappropriate growth, TA breast, TA prostate, and endometriosis. Reduction of secretion of this hormone either leads to menopause or hypogonadism. Androgens. Testosterone is the predominant natural androgen. They are mainly secreted by the Leydig cells of the testes. They bound to hepatic glycoprotein known as sex hormone binding globulin, 65%, and around 33% is bound to albumin. Only 1 to 2% of circulating testosterone is freely available because it's bound very extensively to the globulin proteins. It is converted into active dihydrotestosterone by hydroxylation. What is the hormone? What is the hormone converting testosterone into dihydrotestosterone? You all should know that is basic thing. So the function of testosterone, it used for normal spermatogenesis, normal sperm production, and it's very important in your secondary sexual characteristics and for the sexual potency. That is very important. If you don't have that potency, we call them impotence. And for the growth of genital tract at puberty. The androgens also increase protein anabolism. So they increase your muscle mass. So androgen increase your muscle mass and it promotes the bone growth, and sometimes in precocious puberty an androgen overdose, it causes short stature. So when you are going to use the androgen therapy, main thing is when there is primary testicular failure, because testis is the one which have the Leydig cells and they produce androgen. When you have problem in the testis, there's a testicular failure, then you have to definitely replenish or you have to give androgen supplement. So when there's a bilateral anochia, anochia is, what is anochia? Loss of testicular tissue mass. And Klinefelters, if you have undergone a testicular surgery, chemo and radiotherapy, or if there is secondary testicular failure due to problem in the hypothalamus or pituitary. Other conditions also you have to give that, like delayed puberty, angioneurotic edema, adrenal insufficiency in female. Testosterone replacement improves libido and the overall sexual performance in hypogonadal men. Because these libido and the potency of sex are very important factors in your sexual life and your. So, what I am trying to say is it's very important because if it is not satisfactory for your partner or you feel that you are not performing well, then it causes problem in the family. You become depressed. She become depressed. She become depressed. He become depressed. So these causes problems in the family. You may understand why this factor is very important because nowadays when a brilliant or excellent consultant prescribing drugs, even for the hypertension, a diuretic or something, they always ask about the sexual history. Because a woman is 60-year-old, she is on menopause, that doesn't mean she is not sexually active. Okay? Even after menopause, they are sexually active, so they need drugs for that. Estrogen, they supplement them. Okay? So these are very important concepts which have a severe effect on the person's day-to-day life and family life. We usually tend to forget because we have a stigma in our mind. If we ask this kind of thing from patient, we are talking nonsense. No, we are talking with a sense. So hereafter, future doctors, remember, whenever you are prescribing a drug and you know the one of the side effects of that drug is loss of libido or it affects some sexual potency, don't forget to ask sexual history from the patient. Okay? But its effects on erectile response is not clear. But definitely it improves the libido. Oral, buccal, transdermal, and depot, that means injection formula are available. Oral preparation is mainly testosterone androgens. It's highly lipophilic, and when you are giving orally, it absorbs from the intestinal lymphatics and thereby bypassing extensive hepatic metabolism. Yet their bioavailability is poor. The T half is short and it is converted to dihydrotestosterone before absorbed because dihydrotestosterone is the active form of that. Parental preparation, you have intramuscular injection. The name is sustanon, not the sustagen. Sustagen is the protein, protein-rich milk powder, sustanon. And you have to give in a 1 to 2 week interval, and it has a very good safety profile. The main disadvantage is the fluctuation of plasma testosterone concentration, causing mood swings and swings in the well-being. Not only the female will have mood swing, they usually have, even male will have mood swing. Okay, but testosterone antagonist, when you are giving a depot injection, it achieves stable physical concentration for 3 months. There are transdermal patches, you know the patches. You can apply that for the scrotal or non-scrotal area, but mainly we apply for the scrotal area because scrotal skin, it have high concentration of 5-alpha reductase that is needed for the conversion of testosterone to dihydrotestosterone. Okay, and the scrotum skin is highly vascularized, so the absorption is quicker and superior than other part of the body. There are few. This is the transdermal patch. This is the this is not the depot. This is a kind of implant. Like in your female contraception, you are giving progesterone implant. These are testosterone implants. Okay. So when you are giving the skin patches, you will get local skin reaction that is around in 10% of cases. They are mainly secondary to the absorption enhancers. What are the absorption enhancers you are using? Mainly alcohol. Okay. And you have to change these patches every 24 hours. That means every day you have to put a new patches. And after you apply the patch, avoid bathing for 6 hours. Okay. And avoid close skin contact with other humans where the patch is applied because that can cause transmission for other one. There are buccal preparation you can put in the buccal, that means in the small depression above the incisor tooth. So it will bypass the first fast metabolism, hepatic metabolism. There are implants, I show you. These are implants. The implants, what you do is you have to put in the anterior abdominal wall, or some people put in the buttocks also. You have to put 3 implanted pellets. It gives hormone for around 6 months. What are the adverse effects of this androgen replacement? So increased libido may lead to undesirable sexual activity. So too much of anything is not good. So if you have too much of libido, that also affect your day-to-day life. Okay. In some women, the virilization is not desired. And androgen have a weak salt and water retaining activity, but it is not often clinically important. The liver injury can occur, but these are reversible once you stop that. So the monitoring the while the patient is on androgen treatment, you have to monitor prostate specific antigen because CA prostate is a contraindication for androgen usage. You have to monitor hemoglobin SL because it can cause polycythemia. And in patient with malignant disease of bone, androgen administration may be followed by hypercalcemia. So what are the androgen antagonists? Anti-androgen. When there is too much of androgen in your body, you have to suppress that. So we'll give androgen antagonist. So estrogen and progesterone are physiological antagonists to androgen, but we have produced some components like cyproterone. It's a derivative of progesterone. Its combination of structural similarity and differences result in competition with testosterone for receptors. in target peripheral organ, that is competitive antagonist activity. But as it is causing reduction in the androgen activity, it not forcing feminization as estrogen does. It reduces sperm production while you are taking this, but it will back to normal 4 months after discontinuation of the drug. The abnormal sperm production or count can occur during treatment as they are competitive with the normal testosterone. Your sexual drive may be reduced and it causes impotence. So where we are using the indications are reducing male hypersexuality. So it is a very controversial topic. How to define hypersexuality is a different lecture. Okay. And prostatic cancer, severe female hirsutism, we use that. Flutamide and bicalutamide are non-steroidal anti-androgens. There are other drugs called finasteride and dutasteride, because we said the testosterone is converted to dihydrotestosterone, that is the active form. We have to block, you need 5-alpha reductase to do this conversion. If we are blocking this conversion, the active component dihydrotestosterone is less. So the androgen activity will be reduced. So that these drugs, finasteride and dutasteride, they inhibit conversion of testosterone to dihydrotestosterone or DHT. It is useful in BPH, benign prostatic hyperplasia. Spironolactone also have anti-androgen activity. It may help in hirsutism in women as an incidental benefit to its diuretic effect. So spironolactone, it have a diuretic effect as well as anti-androgen activity. That is an MC. Sorry. Ketoconazole, you may study that. That is a antifungal drug. It interferes with the androgen and corticosteroid synthesis by inhibiting the cytochrome P450 enzyme, which are involved in steroid biosynthesis. So it may be used in prostatic carcinoma or Cushing syndrome. Metirapone also blocks aldosterone synthetic pathway. So anabolic steroid. Androgens are effective protein anabolic agents, but their clinical use for this purpose is limited because it causes virilization that women will not tolerate. There were a lot of attempts to separate anabolic effect from androgenic action, but it is not that much successful. So all anabolic steroids also have androgenic effects. They benefit some patients with aplastic anemia. That is again common true false MCQ. I forgot to highlight that. Okay. So the anabolic steroid can prevent the calcium and nitrogen loss in the urine. So if a patient is bedridden, usually they lose calcium and nitrogen because the muscles and bone are not getting used. So you can give these these anabolic steroids, so they prevent the loss. Sometimes it has been used in the treatment of severe fractures as well. Okay. Acne and greasy skin may be the early manifestation of virilization. All are MCQ points. Then we come to estrogen. Estrone and estradiol are both natural estrogen. Estrogens are responsible for female secondary sexual characteristics, uterine growth, thickening of the vaginal mucosa, development of the ductal breast system. So development of the ductal breast system, you need estrogen. Development or deposition of the fat in the breast, you need. For globular development, you need progesterone. The preparation of estrogens. There are variable preparation available. Depends on the T-half and pharmacotherapy. Ethinyl estradiol. The T-half is 13 hours and it is a synthetic agent of first choice for pharmacological use. So ethinyl estradiol is the first choice. It can be used in contraception, female hypogonadism, and menstrual disorders. It is effective by mouth 20 to 50 microgram per day. Estradiol and estriol are orally active mixed natural estrogens. The dose is 1 to 2 milligram per day. So ethinyl estradiol, estriol. Very important to know these three. There are conjugated estrogen preparation and there are orally active synthetic conjugate preparation, estropipate, and the first synthetic estrogen is diethyl stilbestrol, or we call it stilbestrol. It is used rarely in prostatic cancer and occasionally in postmenopausal women with breast cancer. So there are a lot of estrogen preparations available. So how you are going to choose it? The choice of estrogen depends on again its pharmacokinetic activity. The weaker endogenous estrogen, estradiol, estrons, or conjugated equine estrogens are preferable for physiological replacement. Okay, the weaker endogenous ones are preferable. So there are other category called selective estrogen receptor modulators. They have combined estrogenic and anti-estrogenic properties, raloxifene and tibolone. So that means same drug, one drug is having an estrogen activity at one receptor or one place, anti-estrogen activity in different place. Raloxifene has an anti-estrogenic effect on breast and endometrium. That means your uterus. But estrogenic effect on bone. So it is used for prevention and treatment of osteoporosis. Because it will not get post breast cancer or endometrial cancer, but it will increase the bone deposition. Raloxifene has an anti-estrogen effect on breast and endometrium, but it has estrogenic effect of bone deposition in bones. It is again a famous concept and a famous question. They will ask question, in a CA breast person, you give raloxifene to prevent osteoporosis. Explain the pharmacological basis. So if you have to explain this, okay? This raloxifene, it reduces the risk of invasive breast cancer, but of course it increases the risk of stroke and thromboembolism. It does not affect vasomotor symptoms. Tibolone is a license for short-term treatment of osteoporosis. Estrogen, you can administer as oral. There are transdermal patches, subcutaneous implants, vaginal things. Mainly there are vaginal creams, gel-like cream. Postmenopausal women use this mainly to avoid vaginal dryness, because vaginal dryness is a serious problem in postmenopausal women. And even the nasal spray you are having. So when you are going to use that, what are the indications for that? It mainly used as a replacement therapy where estrogen is low. Usually the ovarian or hypothalamic disease where estrogen production is reduced. Treatment is by cyclic estrogen. That means you give estradiol, conjugated estrogens, or ethinyl estradiol continuously with progesterone. You are giving last 10 to 14 days of estrogen treatment. That is cyclical treatment. It's an alternative treatment. So that means rather than giving this, you can give oral contraceptive, because oral contraceptive is having estrogen and progesterone in the similar fashion. So an alternative treatment for this is oral contraceptive. So you have seen there's something called progestogen. So what is the difference between progesterone and progestogen? It's very simple. Naturally, synthetic things in your body is progesterone. If you are synthesis that in the outside, you are producing mechanically, that is progestogen. That is the only difference. Okay? Don't get confused with what is progesterone, progestogen. Progesterone is naturally synthesized in your body. Progestogen is you are synthesized outside. So it can be used in postmenopausal hormone replacement therapy, because use of estrogen treatment to reverse or prevent problem due to the loss of ovarian hormone secretion after menopause. We call it HRT, hormone replacement therapy. The tissues which are sensitive to estrogen are your brain, bone, skin, your heart, your genitourinary area, your vagina and urethra. So these are the symptoms of menopause. We have increased cardiovascular risk. There will be mood swings. So that is a controversial topic. The mood swings can happen before menopause as well. Joint pains, weight gain, dry skin, headache, vaginal dryness, irregular periods, insomnia, concentrating problems. Again, that's a controversial topic. So or tender breast, memory problems. See, because of this menopause, the problems on the earth are happening in one woman. So how terrible it is. Mainly because of one hormone, estrogen. Of course, progesterone has a part, but mainly because of the estrogen. So we have to give externally. The goal of giving HRT is to reduce mainly the vasomotor symptoms like I told you, hot flushes, sleeplessness, vaginal dryness. The menopause women will complain you, they feel some kind of burning sensation under the feet, the back. So if those are we call hot flushes. Then they will have some kind of sweating, night sweating, evening sweating. They complain different things. Okay. Cancers may be more common with estrogen treatment, like breast and endometrial cancer. All type of HRT, some are given with estrogen. So some HRTs are estrogen with progesterone, some are only estrogen. All type of HRT effective in reducing the hot flushes experienced by more than 50% of postmenopausal women. The benefit is most during the first year of treatment when 75% of women reported reduced likelihood. By the end of 3 years of treatment, it reduced to 65. So, what are the preparation used for HRT? Women without a uterus take continuous estrogen alone. Women with uterus require estrogen combined with progesterone to prevent endometrial proliferation and risk of endometrial cancer. There are sequential forms and there are fixed or continuous forms are available. Continuous combination of HRT will eventually induce amenorrhea in most women. Okay. Contraception. Can the HRT used a contraception? HRT in routine does not provide contraception, but for an alternative for HRT, you can use contraceptive drugs. That means contraceptive pills. But HRT does not provide contraception. So any potentially fertile woman who require HRT should take appropriate precautions. A woman is considered potentially fertile for 2 years after her last menstrual period if she is under 50 years of age. That is 1 year if she is over 50 years. So the woman who is not producing menstruation, that doesn't mean she is not fertile. So always use appropriate precaution. Okay. A woman can use a low estrogen combined oral contraceptive pill to provide both relief of menopausal symptoms and contraception. I told you. So what are the adverse effects of HRT? The commonest reason for withdrawal are irregular bleeding and breast pain. The concern about musculoskeletal symptoms and weight gain have not been substantiated in long-term trials. The transdermal patches were associated with skin reaction because the alcohol content sorry, because the alcohol that is the transfer mediator or the transporter of these estrogen, it produces some skin reaction. So as the alcohol content is reduced in newer formulation, the adverse effects like skin reactions are reduced. Alcohol is used as a solvent. It helps in skin penetration and it maintains the stability of your drug. The more serious complications are venous thromboembolism and cancer of endometrium or breast. But these risks are absolutely small. Okay. Carcinoma of the breast can occur with any type of HRT. There's an increased risk of gallstone by 2-fold, but HRT does not increase the risk of ovarian cancer. What are the contraindications to use the HRT? The reason arterial or venous thromboembolic disease because HRT causes this. And we usually don't use if there is a history of estrogen dependent cancer. Then there are few other things. Anti-estrogen drugs. So they are selective antagonists of estrogen receptor are either used to induce gonadotropin release in anovulatory infertility, in polycystic ovarian syndrome, to increase the LH surge, you may use that. Or the block the stimulation of estrogen receptor positive carcinomas in the breast. Clomiphene is the very important drug used in fertility. It is a partial agonist of estrogen, having less activity than natural estrogen. Its occupation of receptors result in antagonism. The clomiphene blocks hypothalamic estrogen receptors so that the negative feedback of natural estrogen is prevented and pituitary responds by increased secretion of gonadotropin, which will induce ovulation. Again, mechanism of action of clomiphene is a common SCQ question. It should be on your fingertips. So the hypothalamus produces GnRH and it acts on pituitary. Pituitary produces LH and FS. The LH comes in at the ovary. It introduces ovulation. The ovary produce estrogen. They give negative feedback. But the clomiphene citrate block it. So no negative feedback. More GnRH. So more LH. So high chance of ovulation. So clomiphene you can take from the day 2 to day 6 of menstruation. It's successful in inducing ovulation in 85% of women, but multiple ovulation and multiple pregnancies are occur. People think that is adverse effect. Is it adverse? No. You are getting two babies at one pregnancy. It is luxury. Even though pregnancy will have a lot of other normal complications, but it is luxury, isn't it? Tamoxifen. It is a non-steroidal competitive estrogen antagonist on target tissue. Okay. It usually used in treatment of estrogen-dependent breast cancer. The hormonal treatment of choice in women with estrogen receptor positive metastatic breast cancer. So here the estrogen bind with estrogen receptors and causes breast cancer cell to proliferate and for angiogenesis and metastasis. The tamoxifen will come and bind with the estrogen receptor. So it blocks the activity of estrogen. So it used in breast cancer. Severe adverse effects are unusual with tamoxifen. But the patient should be told the small risk of endometrial cancer. So here estrogen comes and binds with estrogen receptor, the breast cancer cell causing more proliferation. But the tamoxifen, it blocks the estrogen in the breast cancer cell, so the proliferation is reduced. But tamoxifen, it acts as an agonist in uterine endometrial cell, so it causes proliferation of the cell. So tamoxifen is a useful drug. So you will get a question like this. Tamoxifen is used in cancer of breast, but it has a potential for endometrial cancer. Explain the pharmacological basis. You have to explain. I am giving you essay question. You have to practice. The progesterone and progestogens. I have told the difference. The progestogens are two principal kinds. One, they are derived from progesterone itself. Others, it came from testosterone. You produce that from testosterone. They use in contraception, menopause, and HRT. Other possible uses I have listed. You have oral, suppository, pessary, injectable preparation. Drospirenone is a synthetic aldosterone antagonist. It's a kind of progestogen. It has anti-mineralocorticoid activity. It exhibits partial anti-androgenic activity. It is available as a combination with ethinyl estradiol for use as contraceptive. Okay. It causes tumors in the breast of beagle dogs. Antiprogestogens. Antiprogestogens are mainly because why you need progesterone in pregnancy for the implantation, endometrial stimulation, suppression of uterine contraction, and even for the placenta formation, you need that. If you are blocking the progesterone, then it will cause sorry abortion or termination of the pregnancy. These antiprogesterone are used in the legal termination of pregnancy. For that, to decide the legal termination of pregnancy, one thing is the baby might have anencephaly or the head is not there, only the body is there, like that. Any severe chromosomal abnormalities, it is not suitable for live baby. Second indication for legal termination of pregnancy is the pregnancy is life-threatening to the mother. Those are the two things. If other different indication people are doing that, that is illegal abortion, that is criminal abortion, and it is a serious offense under Sri Lankan Act. Okay. To decide to go for a termination of pregnancy, 2 VOGs has to confirm that. One VOG's confirmation is not enough. 2 VOGs has to confirm, yeah, we need to do legal abortion. Okay. Mifepristone is the drug. It's a pure competitive antagonist. It is safe and effective in terminating pregnancy, but the efficacy is enhanced by mifepristone is given orally. After oral administration, you have to give vaginal prostaglandin to increase uterine contraction. That's how the efficacy is enhanced. It can cause nausea, vomiting, dizziness, abdominal pain, uterine bleeding, may be heavy. Mifepristone is also offers the opportunity for mid-trimester termination. This is how it acts. The mifepristone, it blocks the BCL2 because BCL2 is needed for the endothelial cell survival. Mifepristone reduce the BCL2 factor, so degeneration of decidua and villi. It increases the BAX2, so it causes apoptosis. That is how it works. So there are a few guidelines how to use mifepristone in 1 week pregnancy and mid-trimester pregnancy. Other progesterone derivatives, danazole. It has a little progesterone activity. It's relatively selective inhibitor of pituitary gonadotropin secretion, LH and FS. Just go through this. Okay. With that, we have completed sex hormone, and the next is oral contraception and hormones. Contraception by drugs and hormones. See the varieties of drugs. The requirement of successful hormonal contraception is tough. The following represent the idea. Your contraception must be extremely safe and highly effective. Its action must be quick in onset, quickly and completely reversible, even after years of continuous use. It should be quick in onset, but once you stop it, it should again regain the fertility sooner. And very important, it must not affect libido. Hormonal contraception in women, either you can use combined estrogen and progesterone or progesterone alone. Combined contraceptive, we call it the pill. The women in the Western will ask, the West they will learn, I on pill. That means I on contraception. The mechanism of action, there are three mechanisms of action for the combined oral contraceptive pills. One is, you should remember the hypothalamus pituitary gonad axis. Inhibition of ovulation through suppression of LH surge by the hypothalamus and pituitary. In addition, endometrium is altered because endometrial proliferation and vascularity is very important for implantation. If you alter the endometrial thickness, then implantation will not occur. Then cervical mucus become more viscous or thick. If the cervical mucus is become more thick, the sperm cannot swim through. So that is, these are the three mechanism of action for oral contraceptive pills. This is what I said, the axis, just go through that. The oral contraceptive pills, usually we give for first 21 days starting from day 1 of menstruation. For the next 7 days, either you don't give any tablets or you give placebo, vitamins or iron. During that period, the withdrawal bleeding will occur. Why we are giving placebo is mainly for the compliance. If we ask to take 21 days, then break for 7 days, then again a second circle or cycle, there are high chance they will forget. But if they are taking tablet every day, so they will continuously will take. Important aspect is when you stop taking combined oral contraceptive pill, usually your fertility will regain within a month, but it may be take a longer for few people. Although progesterone can masculinize the female fetus, the doses for contraception are very low, so it is not harm if a woman who is undiagnosed pregnancy is taking that. The breast and cervix CA are slightly increased in incidence, and there's a risk of hepatoma also. But remember, the risk to life seems to be less than that of moderate smoking and then that of normal pregnancy, because the risk of pulmonary embolus are higher in normal pregnancy. So I all think the pregnancy is risk. Yeah, the pregnancy, even though it is physiological, it is risk for that pregnant mother. That's why we should treat women in a high standard because they risk their life to give birth to men like us. That is one of the reasons why I always respect women. Okay? The risk of carcinoma of the ovary and endometrium is substantially reduced. The breast and cervical cancer risk is slightly increased. Ovarian and endometrial tumor risk is reduced. The overall incidence of cancer is unknown. The combined oral contraceptive pill, it is one of the best pills to regularize the menstruation. If young female women, teenage women come with irregular menstruation, the best way to treat them is giving combined oral contraceptive pills for 3 months, and most of them, the menstruation will be regularized. But because of the stigma in our society, women think if they take these pills, the fertility will affect in the future. So that stigma is there. So we have to deal with that as well. Often the combined oral contraceptive pills, the effect on menstruation are it regularizes it, reduce the blood loss, it can cause amenorrhea, but breakthrough bleeding can occur, and mainly it will reduce the premenstrual tension and dysmenorrhea. You should know what is premenstrual tension and syndrome, PMS. I believe you know that. Then libido. It is a psychological information. Mainly, if you are afraid that you will get conceived when you are having sex, then your libido will be reduced because of the anger, because of sympathetic, parasympathetic alteration. But if you are on contraceptive pill and you think and you believe I won't get conceived because I am on pill. So the fear is not there. So when you do or perform sexual activity or intercourse, you believe the libido is kind of increased. So that is a psychosocial influence. Okay. It is likely that the direct pharmacological effect on libido is rare. To reduce the libido or increase the thing. Cardiovascular complication. The incidence of venous thromboembolism is increased in pill users, especially in smokers, because in foreign countries the women are smoking. Maybe in our countries a small percentage of women are smoking. In smokers, hypertension, cerebrovascular events, and acute MI are slightly increased. The third generation tablets appear to carry a high risk of venous thrombosis. So before the surgeries, you have to reduce that because surgery causes antithrombin level. This pill is increase the thrombosis, so risk is there. So just go through that. So these are other preparations. Just read it. So what are the endocrine effects of the combined oral contraceptive? One is prevention of normal premenstrual rise and mid-cycle peaks of LH and FS. Increase hepatic synthesis of protein, including thyroid binding globulin, ceruloplasmin, transferrin, coagulation factors, and renin substrates. Reduce carbohydrate tolerance, decrease albumin and haptoglobin synthesis. So these are the absolute contraindications. Pregnancy and breastfeeding are absolute contraindications. These are relative contraindications. The estrogen increase clotting factors and reduce the efficacy of oral anticoagulants. Again, a common essay question. Combined oral contraceptives will not be used with anticoagulant. Oral anticoagulant is what? Warfarin. This is not contraindication to their continuous use, but you should be alert. You need to monitor the INR level. Or they may ask question like that. A patient who is on oral warfarin, he prescribed combined oral contraceptive by a physician, and the physician asked her to monitor her INR level frequency or frequently. What is the pharmacological basis behind that? So you see, these are the questions come. And these increase the renin secretion, so it has some effect with antihypertensive drug. Renin is increased hypertension, so there are some problem. And enzyme inducers like rifampicin, carbamazepine, phenytoin, St. John's wort decrease the plasma level of contraceptive. What is St. John's wort? I think 90% of you don't know what is St. John's wort. St. John's wort is a plant. It's a herbal. It used for increased sleepiness, release stress and anxiety in the ancient time. Still some people use that. Okay. If you don't know what is St. John's wort, just go through that in the internet, because they tend to put that name in the MCQs, because you will not know that. So other things just go through, nothing. Then important thing is postcoital contraception. This is we call morning after pill. That means you have intercourse with your partner or someone which you know in the club, or you went to party and have a intercourse under influence of something or without the influence of something. Then early morning you come to your normality. You bring back your lost wisdom. Then you think, I have done this, then what I'm going to do? Then you have to take this step. That's why we call morning after pill. You have to take in the morning after you regain your lost wisdom. Okay? It consists of 1.5 milligram levonorgestrel. You have to take the sooner you take, the better the result. Probably within 12 hours. If you are taking after 72 hours, the efficacy is reduced. It prevents approximately 84% of expected pregnancies. If vomiting occurs after taking that, within 3 hours, you have to repeat the dose. Okay? So don't use that. Then there are progesterone-only pills. It's available as oral depot injection. You get that for 3 months. And subdermal implants like Jadel. And you can have IUD, intrauterine devices as well. The single flexible rod implant releases etonogestrel. The intrauterine device releases levonorgestrel directly into the uterine cavity. So it is licensed for the contraception and the treatment of primary menorrhagia. You can keep that IUD is effective up to 5 years, usually Jadella for 3 to 5 years. The uses are contraceptive effectiveness is less than with combined pills. But combined pills are contraindicated in pregnancy and breastfeeding. Progesterone only is contraindicated in absolute contraindication in pregnancy only. So in breastfeeding, if you want, you can prescribe that, but with precaution. These are the absolute contraindication. Go through that. Few adverse effect, you will get occasional breast tenderness and the bleeding may be irregular. Uncommonly, you will get nausea, headache, appetite disturbance, and some kind of altered libido. These are the reference for that. And if you have any question, you can mail me or you can WhatsApp me. Hope you all are my brilliant students. You understood this very well. Now, as always said, peace be with you always and have a great day. Thank you very much.